This week we'll talk about shoulder instability. So we'll talk about macro instability, which really has to do with the glenohumeral ligaments, the labrum, capsule, and the bones, and then micro instability, which some people talk about, which really is a smaller percentage of the instabilities and primarily the superior structures. So you're all familiar with the glenoid. In fact, for those of you who were at the lecture this morning, Karen talked a little bit about instability patterns of the bony glenoid. But here we have the bony glenoid, and then there's the superior band of the inferior glenohumeral ligament, superior band of the inferior glenohumeral ligament, and the area around the axial pouch here. The middle glenohumeral ligament really comes from the a little bit medial to the margin of the labrum, and really attaches to the deep subscapularis tendon. In the axial plane, if we do an axial cut, we have the subscapularis muscle and tendon. Here's the capsule here. The middle glenohumeral ligament would come down like this, which we'll see in a little bit. Anterior labrum, posterior labrum, and posterior capsule. And as you can see, a lot of people use the analogy of the glenoid being like the T and the humeral head being the golf ball. It's intrinsically the most unstable joint of the body, but that's because it requires the greatest range of motion to be functional. So this is what it looks like in the axial T1 weighted images, which you guys have seen 1,000 of. Here's the humeral head, intertuberous groove with the biceps that we talked about last time. Here's the subscapularis and its attachment to the lesser tuberosity. Right in through here is part of the middle glenohumeral ligament that we'll talk about more later. Anterior labrum, posterior labrum. There's a lot of variation normally in the labral structures. This one just has a small posterior labrum. And then here we can see the posterior capsule back in that area. If we if we go to the anterior superior area, there's a lot of confusing anatomy in this region. Here we can see the anterior superior labrum, posterior superior labrum, the articular cartilages in here. This is the superior glenohumeral ligament coming across here. And coming right off of this attachment here to the glenoid, it attaches to the superior labrum, superior glenohumeral ligament. And this is also the attachment of the inferior glenohumeral ligament, which will extend inferiorly. And occasionally there's a variant where the anterior band of the inferior glenohumeral ligament will come all the way up and attach to the same location, which can be confusing, which we're going to talk about. On the sagittal plane, we can see that same area where a lot of confluent structures come together here. This happens to be the middle glenohumeral ligament coming here, superior glenohumeral ligament up in this area, labrum, this is the subscapularis tendon down here, and part of the anterior band of the inferior glenohumeral ligament coming down through there. And this area between the anterior margin of the supraspinatus muscle and the superior margin of the subscapularis muscle is the rotator cuff interval that you're all familiar with, and that's necessary to allow the coracoid process to intervene in through here. So these are the different structures that we're going to be talking about. So there are a lot of anatomic variants here. We'll talk about sublabral recesses. That's almost always seen superiorly in middle-aged and older individuals. There's some debate about whether it's congenital or whether it's acquired, because you really don't see it in young kids when you do it. So part of it may be a little bit of acquired, but generally the important thing here is not to overcall it as a slap tear, because many people were repairing these, as we'll see a little bit later, which led to poor results because it overly constrains the shoulder. Then there's a sublabral foramen, maybe 20% of people, so it's a pretty common finding. A Buford complex, some people say anywhere between 2 and about 7% of people have a Buford complex. And then there's a superior insertion of the inferior glenohumeral ligament, and then we'll talk about Plicas. So, is somebody dinging something? All right. So labral recess, it's very common superiorly. It's very but it should not be present below the midline of the glenoid. Is somebody clicking something, making that noise? Okay.
I'm muted, right? So I don't know what that sound is. I hear it too.
Interesting. And John is muted as well. I don't think I'm doing anything. Oh, well. Okay.
I'm not hearing anything.
Oh, okay. Okay, so so here we go. Here is basically a T2 coronal and a PD fat set coronal. We can see a lot of degenerative changes here, but if we look in the area of the superior labrum, this is going to be up here is the biceps anchor. Down here is the superior labrum. Here is the articular cartilage, and we can see there's a little bit of a cleft between the labrum and the articular cartilage. This is a very small one in this particular case. Here's the articular cartilage. Here's the surface of the articular cartilage, the labrum, and the biceps anchor, and we can see there's a little cleft here, a little bit of a recess. I don't really comment on these when they're this small. So that's a little superior recess. More prominently, here's also a superior recess. A couple of things to note here. One is we can see the superior articular surface is nice and smooth and not interrupted. If you had a tear in this location, you'd expect the margins of the tear to be more irregular. We can see the fluid extending here. We see that there's no high signal intensity extending out into the labrum itself. The biceps anchor is intact, and this is another superior recess that's considered to be a normal variant. People in the past have looked at the thickness here, and that doesn't really correlate between whether this is considered a normal variant or pathology at the time of surgery. So this thickness doesn't really help very much. It can be up to 4 or 5 millimeters, and still arthroscopically doesn't correlate with what's considered a surgical tear. Tears more reliably are determined if you have increased signal intensity, which extends out into what should be the black triangle of the superior labrum. And here we can see the rest of the articular cartilage and the inferior labrum down here in this arthrogram. And this is what the superior recess looks like in the axial plane. Okay. Okay. So what do you think about this one, Jennifer?
We have two coronal images of the shoulder. This one, the joint fluid doesn't look as smooth as the other one, and it seems as though it may extend posterior to the biceps anchor. I'd have to scroll through it to see, but it could be a superior slap tear. Yeah, that looks like there's increased signal along the anterior labrum. And
so this is a tear. And if we go back again, it's really kind of hard to tell here because the articular cartilage looks pretty smooth, but this is a funny signal that's going up in here between the labrum and the biceps anchor. This could just be superior recess here. So based upon these two, I wouldn't know though. The superior labrum looks a little bit deformed and irregular with a little bit of signal going out into it. If we followed anteriorly, this could be a recess, but it's looking a lot more irregular here. But here we're seeing that there's fluid actually going into the labrum. This would be the articular cartilage. If there was a recess, it would be down here. If there's a sublabral foramen, it would be in this area as well. This is the labrum, so there's a tear going out into the labrum. We can follow it down, and it doesn't go all the way to the inferior labrum. So this was a surgically proven slap tear in this location. Okay, Ashu, what do you think of this case?
So 52-year-old male with increasing pain for 9 months, rule out impingement. It's kind of hard to see here. We're looking at that superior anterior labrum. It looks like there's fluid, and it looks pretty smooth. I mean, it's hard to tell, but it's kind of, this looks like a sublabral recess.
Okay, so you think it's a recess. This was on 6/18/05. Patient came back with persistent pain on 12/20/07, and this is an arthrogram.
On this one, the superior anterior labrum looks pretty frayed. It looks irregular, and I think in superiorly it looks like there might be a tear there.
Well, the margins are pretty smooth here. I don't see any signal going out into the labrum itself there.
Oh, I meant on the axial picture. Oh, okay.
Okay, so here it is.
Yeah.
So this is 12/27/07.
Oh, that one looks pretty smooth there, actually.
Okay.
Looks pretty smooth there.
Okay. Here we go.
Yeah,
Cut.
yeah, that looks the recess. Yeah.
This was called a superior labral tear, and this is what it looked like on 10/21/08. There. So what's happened here?
Looks. Did they debride this?
No.
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 I mean it.
What's that structure
So that's
going into the bone?
So this is 6/18/05. You called that was probably normal. This maybe it's probably a superior recess. And here was persistent pain. Here we go on 2008. Here it was called a tear. And then here is, this is 2008. It was called a tear before, and this is now 2008. So John's asking you, what is this?
Yeah, it looks like they. I thought this was so this is an anchor, right, for a labral repair?
Right.
That's right.
So this is a patient who had a surgical repair of a superior recess and was not improved by surgery.
But that labrum and that part of it, of the anatomy, John, is not clear cut, is it?
No, it's not clear cut. Back in 2008, it was quite the rage to repair slap tears. Then a number of papers came out showing that the patients did not do well because it overconstrains the shoulder. So now people are much more judicious in who they select to do repairs of the superior labrum in order to not to overly constrain the shoulder.
And Dr. Snyder named this condition. He happened to be at USC as a resident when I was a professor there. He was interested in knees, and then he decided to go into shoulders, and he made quite a good decision because everybody was going into knees then. And he decided shoulder, and he became quite well known for the shoulder.
We'll talk more about him, and I'm sure you guys have seen a lot of his patients.
He's an excellent surgeon.
Yeah, absolutely. Okay, Jennifer, what do you think of this case?
Well, this looks like an axial arthrogram, and there is some irregularity along the anterior labrum, but I don't see fluid signal intensity going across the chondrolabral junction. Okay. Yeah, there's a small amount of linear contrast signal at the chondrolabral junction, but there's no full thickness enhancing tear.
It doesn't go all the way through. There's no displacement of the labrum.
Yes, injury.
This is called the labral tear in surgery, but they didn't actually fix it. Okay. So here's a case where we can see this is that anterior superior portion of the joint space, and we see a bunch of different structures here. There is a sublabral foramen. This is more anteriorly superior in the area where you can have a normal defect in this location, deep to the labrum. So this is called a sublabral foramen. in that location. There's a middle glenohumeral ligament here, the labrum, the bone, and here's the articular cartilage. Typically, you can see these on 1 or 2 cuts. And again, you have these nice smooth surfaces, and it does not extend into the superior labrum, nor does it extend down to the midline in the anterior labrum. So this is a typical sublabral foramen, which are quite common and shouldn't be misinterpreted as tears. Ask you, what do you think of this case? And let me just point, it has a lot of images here, but what we're really kind of looking at is what's happening over in this area of the anterior labrum.
Okay, so it looks like the anterior labrum's absent. Don't really see much of an anterior labrum. Kind of just goes, and then you see this, I think that's the middle glenohumeral ligament coming down. This is Buford.
So this is the long head of the biceps, superior glenohumeral ligament. Here, this is really where the middle glenohumeral ligament is taking off. We don't really see much of an anterior superior labrum. This is actually, as you said, the middle glenohumeral ligament coming down. And we know it's the middle glenohumeral ligament because when you follow it down, it's associated with the capsule, but it fuses to the deep layers of the subscapularis tendon. As opposed to another structure, which is here, which doesn't go to the subscapularis tendon, it'll go to the anterior band of the inferior glenohumeral ligament that we'll talk about in a minute. If we go to the coronal images, here's that very thickened middle glenohumeral ligament coming down in this location. And on the sagittal plane, we can see this very thickened middle glenohumeral ligament coming down and fusing with the subscapularis tendon. So this is a classic Buford complex. And if my sources are correct, Buford was an orthopedic resident at UCLA and was doing cadaver studies and found this in about 2% of his cadavers, considered a normal variant. Now people feel that it can be as much as 6.5 or 7%. Okay, so.
I read in one place that it was the Buford is just a name for the complex. I don't know why. That's what Campbell states. So I don't know whether Buford was actually an individual or not.
Yes. I was told that he was an individual.
Like you, I've heard that it was a resident or a staff member at UCLA, but I'm not. Right now, I'm not sure at all.
I've never gone back and actually looked up the paper. Maybe.
Okay, so 28-year-old female with 8 months after labral repair. We have an axial exam, an arthrogram of the shoulder. And on this image, I don't see any suture anchors here, but the anterior and posterior labrum appear intact. I don't see a full thickness tear or detached tear. There's slight irregularity of the anterior labrum, but okay. Again, I'm not seeing any post-surgical changes so far, and there's a slight blunting of the anterior labrum. Yeah.
It says post-labral repair.
So they repaired the anterior labrum. This may be an avulsed labral fragment.
Jennifer, what else do they call these ligaments?
The superior glenohumeral ligament?
Yeah, and middle and inferior.
Yes.
They're also called the capsular glenohumeral ligament anterior.
Okay. So I guess this is a tear of the.
So let me go back again. Here we're at basically the midline. Here we're a little bit higher up. We're getting a little bit of blunting, but still we see an anterior labrum. Here we can see a little thickening of the deep subscap area.
Okay.
Come a little higher, more thickening here.
Uh-huh.
Now we really don't see an anterior labrum.
Okay.
If we go up again, at this point, this structure, which we saw came out of the subscapularis
Okay.
tendon, is coming up higher. We see no anterior superior labrum.
Okay.
And if you follow this structure, it comes back and attaches back here. And if
So that's the middle glenohumeral ligament.
and so here's
Yeah, that anchor is in a peculiar position. And that's for a slap tear.
Mm-hmm.
That's a slap tear anchor.
So is this a Buford complex with a prior labral repair? Or?
so here we go. Here's the coronal plane.
Mm-hmm.
There we can see this. See the structures. There's where the suture anchor is.
Yes.
So
It's at 12 o'clock. I think they probably mistook a Buford complex for a labral tear, and they put a suture anchor in the 12 o'clock. Yeah.
I think Dr. Cruz will agree with you.
Yeah. So it's important to call these right because it can lead to inappropriate treatment if we make the wrong diagnosis. Okay. So here's a 20-year-old baseball player with shoulder plane, rule out labral tear. And what we can see here is that there's a small anterior superior labrum, but we can see this is a big cord-like middle glenohumeral ligament with a lot of edema and thickening of it. And if we follow it down, here it is. We see basically an absence of the anterior superior labrum. And if we follow it down, there's that structure, which is the middle glenohumeral ligament. And we can follow it down, and it fuses with here. This is that same structure. It comes and fuses with the deep subscap. So this is a Buford complex with a middle glenohumeral ligament tear. So the stabilizing structure of the anterior shoulder was this middle glenohumeral ligament and partial tear. And the patient had a little anterior subluxation event, and it produced a partial tear of the cord-like middle glenohumeral ligament. Okay, Ashley, what do you think of this case?
Just a quick question. For patients with Buford complexes, do they have increased anterior instability?
Supposedly not.
They have symptoms like anybody else, but it's for a different reason. So they're misdiagnosed.
Okay.
Remember, the shoulder can have. That's one good reason to do an examination, is to make sure that the problem isn't coming from the neck or some other place.
Good. So Ashley, what do you think of this one?
So on the first axial image, I think there's some irregularity there near the anterior superior labrum. There's some increased signal. I think that's the middle glenohumeral ligament there. Although, oh yeah, that might be some edema there in that humeral head, posterior lateral, and almost looks like it's torn. Is that the? Yeah, it looks like it's torn. Right there.
What is it? What's torn?
I feel like that's a high-riding anterior band inferior glenohumeral ligament, but
yeah, well, you can't say completely here. We had all the images. It comes down here and fuses with the subscap.
Oh, okay. So then that's a middle glenohumeral ligament.
Yeah. So this is it comes down and fuses down here. So this is, and there it is arthroscopically. We can see the tear of that structure right in through here arthroscopically. So this was a tear of the middle glenohumeral ligament. Okay. Good. Jennifer?
Well, there is some low signal intensity material here along the anterior labrum, but I still see a good amount of that labral remaining, but it's slightly irregular.
Here are more images. Here's that cut I just showed you.
Okay. I think this is just where the inferior glenohumeral ligament comes up and attaches there. Middle. gonna.
So if we follow down, this chart up here where our starting point is, where those three structures come together, we start separating here, come down here, and it's important not to miss a labral tear, which I've seen happen. It's not really in the typical plane of a labral tear. Labral tear should be a cross section to the labral attachment. This actually parallels the margin of the labrum and is kind of a thickened structure here. But if you follow that structure down, again, it fuses with the subscapularis. So this is another cord-like middle glenohumeral ligament, but it's not really a Buford complex because you still have a labrum there. And that attaches to, so this is just a cord-like middle glenohumeral ligament. And these, I've seen these called labral tears. But if you follow the anatomy and understand the anatomy, you won't call it a tear. John?
This is basically a thickening of the anterior capsule, and so that can be quite confusing.
And that axial image that looked like it could be a tear was right through this area where you had a little fluid between the middle glenohumeral ligament.
What else I was going to say is that the capsule and the ligament can be torn and degenerated, and also when it heals, it thickens.
Yeah.
And then you think that there's pathology there. Yeah. And there is, but it's healed.
Okay. Okay, so this is a patient who came in and was a possible #1 draft pick out of college, a football player. And he came out to get a second opinion because out here, and we were asked to do an MR arthrogram on him. What do you think of this patient?
So here again, I can see what I think is the middle glenohumeral ligament coming off of the subscapularis. I don't see it attaching there to the labrum, so I'd be concerned about a tear of the middle glenohumeral ligament.
This is probably the subscap. Therefore, this structure here is probably going to be the middle glenohumeral ligament. I'd like to look at all the other ones. Then we have something here that's a little bit irregular, but it's in the area of the labrum. And then we have this other structure in this location. And if we start down below, this is what it looks like down below. What do you think? What's this structure?
Be the anterior band of the inferior glenohumeral ligament.
Let's go up. Here's another cut up. What's this structure?
That should be where the anterior band of the inferior glenohumeral ligament attaches.
Yeah, so that's the anterior band. This is the next cut up.
Okay. So the anterior band of the inferior glenohumeral ligament is torn and displaced along the anterior glenoid.
There's the next cut up. There's this cut.
Okay.
What are these three structures here?
The anterior labrum, I'm not sure what the one in the middle is, and then the most anterior one is the middle glenohumeral ligament.
So what this is the anterior labrum. This is the attachment of the anterior band of the inferior glenohumeral ligament onto the anterior glenoid, and this is the middle glenohumeral ligament. And if we go the next cut up, we can see that these are fusing nicely here. A little bit of degenerative change here. Middle glenohumeral ligament there. And if we go to the sagittal images, here is the anterior band of the inferior glenohumeral ligament. There's the middle glenohumeral ligament. And you can see these structures are really all intact. So this was just a superior insertion of the inferior glenohumeral ligament, but this was called a labral tear. And so the team that had the first round on the draft pick at this time was refusing to think about drafting him because this was called a labral tear. And they didn't want to spend their #1 draft pick on someone who was injured, maybe later down. So by reviewing this and seeing that this is just normal anatomy and some minimal irregularity of the labrum, he then went and was drafted as a #1 draft pick in the NFL. So these variations in anatomy can have significant. For this particular person, it meant about, I think in the first year, it meant about $3 million. I don't know how well he did.
They all get MRI now, don't they, John?
Yeah, they pretty much all get anything that's potentially a problem. They get MRIs at the combine, and people look at them. Okay. Jennifer, are you next? Or is Asher? Why don't you take this?
Hi. Yeah. So there's some irregularity of just the posterior, kind of superior and mid aspects of the labrum. Something's connecting off of it. I think it says posterior plica, case 1. Never heard of that. It's definitely not the labrum itself. It's almost like it's an indentation of the capsule.
So this is the posterior labrum, and this is the infolding of the capsule, which is called the plica. And this is what it looks like on the coronal images. This one was surgically confirmed. Here's another case similar to that. So a lot of people will call these posterior labral tears. There's the labrum, and that's the posterior plica.
That's a thickened synovial membrane.
Right.
And that becomes a plica with injuries, I think.
Yeah. So those are just shoulder plicas. It's an uncommon finding, but just remember that you can get plicas in the shoulder as well. And if it has an appearance similar to these, you should put that in their differential. Because then if they go in, they'll just kind of lyse the plica if they think it's causing symptoms. Okay. Well, okay, so now we kind of talked about some of the anatomy that can be confusing in shoulders. Let's go on and talk about labral tears. One thing are how to evaluate for labral tears. You are familiar with our standard imaging, so we really like to get T2 and PD fat sets in the coronal plane, the T2 not fat suppressed. In the axial plane, we like to have T1 and PD fat set at high field. And then the sagittal plane, we like T2 weighted image with no fat suppression. Now, a lot of people like fat suppression. Some of our referring physicians like fat suppression in the sagittal plane. If that's the case, we'll do 2 sagittals. But I believe it's really essential that you have at least one sagittal sequence which is not fat suppressed. And that's because one of the most common diagnoses we ever evaluate is frozen shoulder. It's very, very common. And to really evaluate for frozen shoulder, you really have to be able to evaluate the rotator cuff interval fat. If you fat suppress it, you really can't evaluate it very well. So I don't think any shoulder examination by MR is complete if you don't have a oblique sagittal non-fat suppressed sequence, and either T1, T2, or PD is fine. So then you can do arthrography if you want. I'm not a big fan of arthrography, as the fellows here know. I don't like any time when you go in and you change the physiology of a joint, because it really changes what you're looking at. You almost always get some extravasation, especially if there's acute trauma. I don't like it because the extravasation can confuse hematomas, hemorrhage, muscle tears, and so forth. But a lot of people like it. Now, if you do arthrography, one view that many people like is the ABER view. So you do a standard arthrogram in the usual position, and then you basically put the arm above the head, reintroduce them in the scanner, and do another scout view, and then do this oblique image here. The concept behind this is by putting initially the concept was by putting the shoulder in this position, you stretch the anterior capsule, and if that's attached to the labrum, you can pull the labrum off and expose a tear that might be more difficult to see if you don't have an ABER view. And this is an example of one of the early cases we did where we didn't see the tear on the standard imaging, but we did on the ABER view, so we kind of got excited about it. And one of the early proponents of this was Phil Turman, who was a fellow of ours when we were in Santa Barbara. And there's still a lot of people who will do this. So the problems with doing this is it's very time consuming. You have to do you have to do an orthographic injection, then you have to do a regular examination, then you have to take the patient out of the scanner, reposition them, often use a different coil, because you can't do this with a standard shoulder coil. Put them back in the scanner, redo the scout view, and then scan them. So it takes more than twice as long as a regular study. And then what you'll find out is a huge number of patients cannot be put in that position because it's terribly uncomfortable. And for any of you who have had shoulder problems, and take it from me, one of the most uncomfortable things you can do if you have shoulder pain is to lie in an MR scanner. And that's even in the anatomic position. If you put the arm up like this, you're even more likely to get symptoms. So it's a cumbersome thing to do. So for a long time, we would limit this to patients under the age of 35 who are concerned about anterior labral tears. But then we did a series of about 200. We found that there are a few cases where we could see the tear best in the ABER view. We had a number of cases where we could see the best in the non-ABER view. So we didn't actually find the ABER view had any increased sensitivity over the regular one. Because sometimes when you put tension on the capsule, it will actually pull the labrum back against the base rather than pull it out. But one thing that we did kind of notice for overhead athletes, a lot of these posterior impingement syndromes that we talked about before, you can see a little bit better in the ABER view, especially the subtle injuries to the posterior rotator cuff in this location. But generally, we can see this. If you know to look for them, you can see them in the regular images. So I personally don't like to do the ABER view, and we almost never do it anymore. But there are some who are fond of it.
I felt that anybody that can hold that position doesn't have enough pathology to bother with.
Okay, all right. Okay, so here's a patient who had shoulder pain, rule out labral tear. This is the regular position. A little bit of funny signal here, but it really looks like it's intact. When you put them in the ABER position, you can see that it actually this is actually a tear that's not separated here. And in the ABER view, we can tear it. So this is exactly the way it's supposed to be. The ABER view was designed. We can see thickening of the labral periosteal attachment here, a typical Perthes type injury that we'll be talking about. So there are times when it can where you can see it, other times where it actually obscures the tear.
Is that labrum peeled off, John?
Yes.
And what is that indentation in the head of the humerus?
Right here?
Yes.
I don't remember. But presumably this would be catching part of the Hill-Sachs injury.
Yeah, I would imagine.
So here's another case where old imaging where we can see some concern about the base of the anterior labrum here. In the ABER view, maybe it's a little bit more prominent, but here we don't see it well on the ABER view either. This patient turned out to have an anterior labral tear. And probably a little bit better seen in the regular view, less well seen in the ABER view because it looks like it's really intact. Okay, now you can have a lot of different kinds of signal. This is if you follow this is the anterior labrum. Here we can see that here's the articular cartilage, and the articular cartilage often goes deep to the anterior labrum, nice and smooth like this. This is really a normal anatomy in this one. This is actually increased signal intensity, not associated with the articular cartilage. This is an anterior labral tear, more of a peripheral position tear. Here is also two signals, one here, which is the cartilage, a second signal there, which wraps around. This is an anterior labral tear, kind of a more typical anterior labral tear. And here's one that's in kind of a different plane. This is a patient who had a recent anterior dislocation. This was a shearing injury that tore the anterior labrum. So the morphology of the signal can be helpful in trying to help see what's going on here. So we talked a little bit about the osseous anatomy before, but typically if you look at the humeral head, normally it's in about 20 or 30 degrees of retroversion. Articular surface is around 45 millimeter. The glenoid, which is something we always evaluate, should have an kind of a pear shape appearance, which we see here, bigger down here and a little bit smaller up here, kind of ovoid and about 10%, and it typically is around 3 centimeters in diameter. Glenoid version is important. As you heard this morning when Karen gave her lecture, the tilt of the glenoid, if you go into the coronal plane, which we don't have here, can be important to help determine whether someone's unstable. Something very commonly that we evaluate all the time is the version of the glenoid. So if you draw basically a line along the scapular blade out to the center of the glenoid, and then draw a line along the face of the glenoid, you'll get an angle here. And the more, if that angle is, if you draw an angle here and it's greater than 90 degrees, this angle right here, then that's retroversion. If it's less, if the angle, if it's less than 90 degrees, if the back of the posterior aspect of the glenoid is more laterally located, then that's antiversion. And retroversion is commonly associated with instability, and it's one of the more common dysplastic changes. We talked about dysplasia of the anterior knee. You can also get all kinds of developmental dysplasias of the shoulder, and poor development of the posterior aspect of the glenoid with retroversion is one of the more common congenital abnormalities that can lead to instability. Sometimes what you'll have is a failure of development of the posterior glenoid, and instead you'll have a large soft tissue posterior labrum here, and that is commonly torn because you get a lot of posterior force on the humeral head in normal activity. If you really need something strong like a bone back here to support it from posteriorly dislocating, if you just have soft tissue like a large labrum, like we'll see in a minute, they will commonly tear, leading to instability. And so you should always look.
And John, is that congenital or from convulsions?
Yeah, it's most commonly congenital, but it can also be due secondary to trauma if you have fractures, especially if you have recurrent posterior dislocations from seizures. That's right.
That's usually due to people with epilepsy.
Yeah, it can be.
Posterior instabilities.
So you should always eyeball this, and if you think that there's retroversion, then you should really measure it. And you can measure it by either MR or CT. Here's the kind of the CT measurement where you go along the blade of the scapula, go to the middle of the glenoid here, draw a line between the anterior bone anteriorly and the lateral bone posteriorly, and then and measure the angle here. If it's 90 degrees, then it's zero version. If it's like this, then it would be retroverted. Here's an example of a congenital dysplastic glenoid. And here you can see there's marked retroversion of the glenoid, but what's really happening here is you have lack of development of the posterior aspect of the glenoid. In order to stabilize the shoulder, this patient instead had a large posterior labrum, which you can see clearly has torn here over time because it just can't handle. You've got intrinsically unstable bones here, and the soft tissues can't handle all the forces. So this is congenital instability of the shoulder. And there are various degrees of it. This would be a normal glenoid. This would be a mildly congenitally unstable with a large posterior labrum and really kind of a rounded posterior bony surface. The previous one we saw was much more severe.
The depth, John,
Yeah.
the depth of the labrum is also important, isn't it?
It is, and that's very variable, right?
And very superior and inferior, anterior, posterior. There's considerable amount of variation.
Right, absolutely. Okay, Jennifer, what do you think of this one?
So 25-year-old male with chronic instability. It seems as though there's posterior subluxation of the humeral head with respect to the glenoid, and the glenoid is very hypoplastic. Congenital dysplasia.
Congenital dysplasia, and obviously a very intrinsically unstable shoulder. There's basically no T here to tee the ball up on. Right. Okay, and here's another example. Here are X-rays, but we won't go through these, but that's just X-rays of congenital dysplasia. Here's another example of severe congenital dysplasia, very abnormal glenoid morphology here. In this case, we have a large effusion, but you can see why this would be unstable. The patient has a lot of degenerative disease and severe congenital instability. Ashu, what do you think of this case?
Looking at this, it looks like there's some abnormality of the anterior superior labrum there, or is this just the anterior labrum? There's some increased signal there. Oh, I see. It looks like partial ossification of the anterior labrum.
Yeah.
Some large.
This is what it looks like on CT scan. So this is ossification of the labrum, and in this case also the inferior glenohumeral ligament. So these can ossify. It's indication of degenerative disease of the labrum. It's not really a cause for instability, but it is an indication that you're developing significant degenerative disease. Okay, so we can look for tears, and here for instabilities patterns we look at anterior, posterior, inferior, superior. You can have multiple areas of injuries, and then we'll look at some of the complications that you can get into with these instability patterns. So labral tears in the anterior area, we look for Bankart injuries, Perthes, Alps, anterior periosteal sleeve avulsion, and Glad lesions. So you're all familiar with the mechanism of injury. Basically, you have a anteriorly displaced humeral head anterior to the anterior margin of the glenoid. It usually goes anteriorly, inferiorly. When that happens, you get muscle retraction. It causes the posterior superior aspect of the greater tuberosity to bang up against the anterior inferior glenoid. This produces a Hill-Sachs fracture in the greater tuberosity and a Bankart fracture in the anterior inferior glenoid. And then this typically will cause a shearing injury of the anterior labrum, and then we'll talk about different repairs. So this is basically what happens. So you have an anterior dislocation. The humeral head bangs against the anterior glenoid, producing the Hill-Sachs injury, and often a fracture of the anterior inferior glenoid as well. Hill-Sachs, as a paper back in 1940, described the humeral head compression fracture in the radiology literature. And here, this is just an example of plate films where you have someone with anterior dislocation. There's the Hill-Sachs injury. You can see it nicely, the mechanism here in this particular X-ray pattern. Here's what it looks like under CT. This patient came in with fixed instability, and there's the Hill-Sachs lesion, and you can see how it's caught on the glenoid, which actually produced the impact. Same thing on an MR examination. There's the Hill-Sachs injury, and there's where it's impacted against the anterior inferior glenoid. And here we can see in this particular patient, it's dislocated. There's no humeral head where it should be here, and the socket with the glenoid. And this is someone who had a non-reducing anterior dislocation. Another example here with a little bony fragment that you have to look for in the acute setting as well, and that's after reduction. Okay. Let's see.
That's the greater tuberosity that needs replacement.
Yeah. Good, Jim. What do you think of this?
It's an interesting place to have a Hill-Sachs lesion.
All right, so we have two coronal images of the shoulder. On the first image, I see the glenoid, but I do not see the humeral head within the glenoid. And then on the next image over, we see the humeral head. So it looks like it's dislocated. Yeah. And diffuse edema.
So this is what happened.
And what else can you say about that?
That there's an osseous contusion.
No, I'm saying it probably was missed. I don't think this is acute.
Because it's on an MRI, yes. Normally they relocate them in the ER.
Yeah, anybody that can wait for an MRI is not acute, and you don't see the edema and fluid, etc.
Mm-hmm.
Is that right, John? Am I correct in that?
Correct, right?
I mean, this is a rare image right here that you're looking at.
Very rare. We don't see this very often. They rarely will come into the MR scanner without being relocated.
Well, unless you're in Russia and you don't have a scanner.
Occasionally, when we've seen this, is occasionally they can't relocate because they either have a bone fragment or a tendon, like a long head of the biceps tendon, which interposes, keeping them from being able to relocate. So that's primarily what we're looking for when this happens, is why they can't spontaneously relocate.
Yeah, you have to make sure you ask about a motorcycle if that happens.
Right. And here we can see an acute Hill-Sachs injury. Acute Hill-Sachs injuries typically have this V-shaped appearance because of the mechanism of injury. And here we can see the bone edema around it. The two other things occur in this location. One is an avulsion, chronic avulsion injuries at the infraspinatus insertion, which are usually subchondral cysts, but they can look very similar. They're in the same location. Notice this is the infraspinatus insertion, so the Hill-Sachs typically occur in the same location as the traction injuries. This is also the same location where you get internal impingement that we talked about under impingement. So those are the three things to be concerned about when you see pathology in this location. These typical V-shaped injuries are Hill-Sachs.
Can I ask you to go back on that last unknown? Is that anteverted glenoid?
I would need to go down a couple more cuts to the midline and see the scapula just to know whether it's anteverted or not, John.
Okay, because it sure looks like it's on an angle.
I'm not sure on this cut.
That may be the way that it's in the scanner.
Yeah.
I don't know.
Yeah.
Yeah.
Okay. And then here we can see more examples of this. This was okay. An airplane crash. John, your motorcycle accident doesn't compare to my airplane crash accident.
Oh, I've seen airplane crash. I had a thoracic surgeon that I treated who survived an airplane crash. His wife didn't survive.
Well, here it
was a little suspicious because the guy had a girlfriend too.
Oh, well, that's.
But he didn't have her after the crash. He was a lot of work for me.
Oh my gosh. So here's an anterior dislocation from Brazil. And here we can see they couldn't relocate it. We can see the fracture, the Hill-Sachs. And here they couldn't relocate it because of the long head of the biceps tendon was caught in the joint space. So maybe this can occur with motorcycle accidents, but it could also occur with airplane accidents. And then there you can see the long head of the biceps in the joint space, keeping them from being able to relocate the humeral head.
It depends on the force, not the device you're riding on.
Yeah. Now we'll talk later about engaging and non-engaging Hill-Sachs. Here's one where you can see that the Hill-Sachs is overriding the glenoid, which produced a clunk and pain. and this would be an engaging Hill-Sachs, but we'll talk more about that and how to evaluate for risk between that. This would be considered an off-tract lesion that we'll talk about later. Okay, let me see. Who did the last one? Ashley, why don't you take this one?
Yeah, so this is a 31-year-old male with shoulder after dislocation. It looks like there's maybe a small wedge-shaped deformity that we partially get on the posterior aspect of the humeral head right there, but I don't really see much edema.
Yeah.
What I do see is looks like there's some irregularity of that anterior labrum right there. Yeah, I don't know if there's looks like a maybe partially avulsed tear there.
Okay, so a couple things here. I'd be a little bit concerned. I don't want to figure out what this is. The labral periosseal attachment should be very thin. It should certainly be no thicker than this. Notice it's very thick here. That indicates that you've had an injury to that attachment, which is a very reliable indicator that you have an anterior labral tear. So that itself lets you know there's an anterior labral tear. Now, as far as the Hill-Sachs injuries, the location of the Hill-Sachs injuries depends directly upon the direction of the dislocation. If you have a straight inferior dislocation, which is much less common, the Hill-Sachs will be on the superior aspect of the humeral head. If you have a typical anterior-inferior dislocation, the Hill-Sachs will be posterior superior part of the greater tuberosity. If you have a posterior dislocation, the Hill-Sachs will be in the lesser tuberosity, often called a reverse Hill-Sachs. Now, in this particular case, we're really we're too low to see the typical Hill-Sachs injury here. So if we go higher, there's the Hill-Sachs injury. So this is just to point out where it's typically located. It's really in the superior posterior aspect of the greater tuberosity. Is where the typical Hill-Sachs is. In this particular location. So here's the Hill-Sachs. This is just the ABER view where we can see an anterior labral tear there, where you pull off the labrum a little bit. But I'm quite confident in making the diagnosis of an anterior labral tear based upon the regular image.
And that looks like periosteal peel with swelling.
Yeah, so this, we'll call it Perthes lesion later when we get to it.
Yeah, right. I was going to say Perthes, but I'll let it up to you, John.
Okay, thank you. So we've talked about a lot of different instability findings here, and on the labrum. Okay, Jennifer, what do you hear?
All right, so 53 years old, rule out labral tear. Just on this one image only, there's some blunting of the posterior labrum. I don't see it at all, and irregular. Yeah. Yes. Okay, here, so there's increased signal along both the anterior and the posterior labrum and irregularity. And then again, just some mild irregularity of the anterior and posterior labrum. And there's okay. Diagnosis. I think perhaps he has multi-directional instability with
Here is on 8/20/2012. Here is on 10/18/2012, and these are similar locations, as much as I could do.
It seems like there's some cortical depression along both the anterior inferior humeral head and the posterior humeral head. I'm not sure if it's just the slice. But
What do you think about the articular surface? That's a piece of the surface right there.
Yeah,
which out.
probably an avulsed piece of cartilage.
That's right.
Okay, so there we can see a full thickness tear extending through the anterior labrum.
Yeah, a 53-year-old, what do you think are his chances of avoiding surgery?
I guess it depends on his symptoms and range of motion, what his daily activities are. I know sometimes these are not repaired. If he has,
Yeah, 53, once you reduce them, and give them a chance to in a sling for a couple of weeks, they usually won't recur because the reason they do get an injury at that time in their life, if this is the first one, which may not be the case, but if it is, they usually will be stable, maybe stiff but stable.
Okay, well, why don't we call it quits here today, and we'll carry on with different appearances. So we're staying with the same disease, but it can have a lot of different appearances. So I want to show you what a lot of these different pathologies look like.
You got a lot more pathology lately, John. What years will do for us.
People still get injured. Okay.
Yeah, it's amazing, isn't it?
Yes.
It seemed to be a little